Romans chapter 3, verses 23 and 24. For all have sinned and fall short of the glory of God, and all are justified freely by his grace, through the redemption that came by Christ Jesus. In this part of our discussion of spinal cord injury, we're going to talk about incomplete injuries. Incomplete injuries are more common than complete injuries. Most incomplete injuries are unique from other incomplete injuries, so each patient will present with a unique set of signs and symptoms. However, there are some that fall into a syndrome, and it's these incomplete syndromes that we're going to talk about throughout this part of our lecture. Abbreviations in this part of our lecture include SCI, spinal cord injury, S, sacral, and LMN, lower motor neuron. The first syndrome we're going to talk about is a hemisection, also known as Brown-Séquard syndrome. Brown-Séquard syndrome is injury to one half of the spinal cord. This will involve damage to the dorsal and ventral horn ipsilaterally, and all of the ascending and descending white matter tracts on that side. Signs and symptoms include ipsilateral paresis or paralysis at and below the level of the injury, ipsilateral hypertonia below the level of injury, and ipsilateral hyperreflexia below the level of injury. Brown-Séquard syndrome is also associated with a unique set of sensory impairments. Ipsilaterally, there will be a dermatomal anesthesia at the level of the lesion and likely extending a level or so below the injury. This means that all skin sensations will be absent at these levels. The senses of vibration and discriminative touch will remain lost on the ipsilateral side of the body in all segments below the injury. Proprioception will also be lost on the ipsilateral side of the body, starting at the level of the injury and including all segments below. However, pain and temperature is going to behave differently. Starting 1 to 3 segments below the injury, the senses of pain and temperature will return. So while pain and temperature is lost at the level of injury and 1 to 3 segments below that, contributing to our dermatomal anesthesia, pain and temperature does return at lower levels. Contralaterally, all sensation will be intact at the level of injury. Vibration, discriminative touch, and proprioception will remain intact on the contralateral side throughout all segments. However, the senses of pain and temperature will begin to be lost on the contralateral side from the injury, starting 1 to 3 spinal cord segments below the level of the injury. In the acute stage immediately following the injury, an individual with Brown-Séquard syndrome will likely lack bladder and bowel control and will experience sexual dysfunction. However, because viscera are bilaterally innervated and the contralateral side of the spinal cord is intact, along with the ascending and descending white matter tracts there, once this edema and the shock period has resolved, individuals who have experienced Brown-Séquard will generally regain functional bladder and bowel control, as well as sexual functioning. And now a brainstorm for discussion with your peers. Why would you see the different signs and symptoms that I indicated in the previous slides? Let's draw out what a brown sequard looks like. So here I have blocked out 1/2 of my spinal cord. A good thing to do to practice your spinal cord injuries is to take these images that have the 2 spinal cord segments on them, place your injury on the top one, and then draw in all of your pathways and look to see which pathways get disrupted by your injury. With this image, I hope to help you understand the 2 major theories as to why we do not experience a contralateral loss of pain and temperature sense at the level of injury when experiencing a brown sequard. I'm going to pull up my pointer because I think that will be helpful. I have a spinal cord here, and I've injured the left half of the spinal cord as shown by the green lines. And I have drawn in the spinal thalamic pathway from 3 different spinal cord segmental levels, or 3 different dermatomes. At the level of injury, the pain and temperature information is entering the spinal cord and is entering into an uninjured area of the spinal cord. The second order neuron, instead of crossing at exactly the same level where its soma is, instead ascends as it crosses. So the axon is ascending at the same time it's crossing and ascends rostral to the injury area so that the second order neuron ends up being undamaged. It gets all the way over to the opposite spinal thalamic tract where it will continue up to the brain, transmitting that pain and temperature information. However, once we start getting caudal to the injury, that ascension of the second order neuron causes it to enter into the injury zone, and the neuron becomes damaged and is unable to transmit information up to the brain. So we now start to begin to lose our pain and temperature sense contralateral to the injury. Even more caudally, the second order neuron is able to successfully cross all the way over to the opposite side and enter the spinal thalamic tract. But because the spinal thalamic tract is damaged at the more rostral level, when those ascending neurons reach the injury point, they are also injured and unable to continue to transmit information to the brain. How far below the level of injury we start to have impairment in pain and temperature sense is variable depending upon the extent of the size of the injury itself. But 1 to 3 spinal cord segments seems to be fairly common. The second main theory as to why we do not experience contralateral loss of pain and temperature at the level of injury is due to collaterals that come off of the first order afferent and ascend 1 to 3 spinal cord segments in Lissauer's tract. I'm going to come to my most caudal neuron here, and we can see here as it's entering the spinal cord, before it even synapses in the dorsal horn, that the central process is sending off collaterals, which are ascending up in Lissauer's tract, and then synapsing on second order neurons in higher segments. And the information, the evidence is they will ascend upward of 1 to 3 spinal cord segments. So that while information at the level it enters cannot get up to the brain because the spinal thalamic tract has been damaged, the collaterals that ascend at some point are likely to synapse on a second order neuron that can successfully cross. So here we see it synapses 1 level above, but this one is not able to successfully cross. However, if it ascends a couple of spinal cord segments, that second order neuron is now able to successfully cross to the contralateral spinal thalamic tract, rostral to the injury, and therefore make it to the brain. As a result, pain and temperature information from this particular dermatome and the one above it is still able to get to the brain, and we're still able to perceive pain and temperature there. But if I start to go more caudal than this particular neuron here, those collaterals are not going to synapse high enough So the second order neurons will all be disrupted at some point along their trajectory. In likelihood, it is a combination of both this first theory with the ascension of the second order neuron and this second theory with the collaterals ascending in Lissauer's tract that explains the absence of sensory impairment for pain and temperature contralaterally at the level of injury, but does not begin until 1 to 3 spinal cord segments below the level of injury. To help with understanding what is happening ipsilaterally, I have now added the pain and temperature pathways from the ipsilateral side, in this case the left side. We can see that damage to the spinal cord segment on that left side not only damages the axon terminals of the central process of the somatosensory first order neuron, but also the soma and early axon of our second order neuron. Thereby, we do not experience the sensation of pain or temperature at the level of injury on the ipsilateral side. Going down to the next segment, now the information is able to enter the spinal cord without impairment, and the second order neuron is successfully able to cross to the contralateral spinal thalamic tract and ascend up to the brain without interruption. And that continues from that point down. Again, how far down we do experience some sensory impairment for pain and temperature ipsilaterally is dependent upon the extent of the injury. So that can again vary from 1 to 2 or 3 spinal cord segments. The next syndrome that I would like to talk about is central cord syndrome. Central cord syndrome is most often due to a hyperextension injury in the cervical spine. As a result, the cervical spinal cord is most often affected, and it seems to have a higher prevalence in older men. It is essentially an abscess that extends outward from the central canal, and it usually covers several spinal cord segments. 4 to 5 or 6 segments are not uncommon. It is mostly going to be within the gray matter, with little impact on the white matter tracts, although in many cases you will see extension into some of the white matter areas. Classic signs of central cord syndrome are the arms being more affected than the legs. Because of this, it has been given the nickname man in a barrel. Picture yourself inside of a barrel, with the barrel running from your shoulders to your hips. While your legs are free to move, your arms are trapped inside the barrel. Another classic sign with a cervical central cord syndrome is the symptoms being distributed in a cape-like distribution, typically wrapping around the more lateral aspects of the upper extremities. The sensory and motor deficits associated with central cord syndrome are highly variable depending upon the extent of the lesion. But the anterior white commissure is always affected and typically one of the first things to be affected. So there is pronounced impact on pain and temperature. There is often sparing or much less impact on the dorsal column. So discriminative touch and conscious proprioception may be spared or have limited involvement. This distinctive difference in the extent of pain and temperature loss relative to discriminative touch and conscious proprioception is known as dissociated sensory loss. The defect will often spread to involve the ventral horns, and in very large lesions, the lateral cortical spinal tracts may also become involved. Because this is really occurring starting in this center part of the gray matter and expanding through the gray matter with little white matter damage, bowel and bladder control and sexual functioning are typically highly functional because we have the ability to get sensory information up and we have the ability to get motor information down. Let's now brainstorm regarding central cord. Why would you see the signs and symptoms that I have just described? Now let's use our drawings and go ahead and draw out a representation of central cord syndrome. Here is my depiction of a central cord syndrome. Your book shows it as a perfect circle in the center of the spinal cord. I show it as an oval. Neither of these is really representative of real life. These abscesses are not nice and round or oval shaped and symmetrical. They tend to be quite asymmetrical and very irregular in shape. But I think this oval gives a little bit better idea of how the dorsal column is often spared and how these spread in a more anterolateral direction than a posterior direction. I've included my lateral cortical spinal tract to show how this tract is spared in this particular injury. However, the abscess can spread outward, and if it does, it will begin to impact the lateral cortical spinal tract. If it remains strictly in the gray matter, you will not see lower extremity signs and symptoms. But if it extends outward, as my blue rectangle is doing, and begins to impact the descending motor tracts, particularly lateral cortical spinal tract, you will see some lower extremity upper motor neuron signs. The next syndrome I'd like to talk about is anterior cord syndrome. Anterior cord syndrome is most often due to a stroke involving a major artery that runs down in the groove on the anterior side of the spinal cord and supplies approximately the anterior 2/3 of the spinal cord. It affects the ventral horn and the spinal thalamic tracts, and also has impact on part or all of the posterior spinal cerebellar tracts and all of the descending motor tracts. Resultant signs and symptoms include paralysis or paresis at and below the level of the lesion. See if you can talk to your peers and determine which type. Would it be more flaccid or more spastic in presentation, and at what locations would you see which? We'll see a flaccid bladder and bowel if the injury were to occur at sacral 2 through 4 levels. However, if the injury is rostral to this, we will have a spastic neurogenic bladder and bowel. Sensory signs and symptoms include a loss of pain and temperature at and below the level of the injury, and sparing of discriminative touch, vibration, and conscious proprioception. Now I want you to brainstorm with an anterior cord why you see the signs and symptoms that I have described. Let's draw in our anterior cord, and then this would be good for practicing your pathways to understand this particular syndrome. So here I've taken out the anterior 2/3 or so of the spinal cord. Your book shows it as a straight across line. Mine's a little more curved. It usually has a little more curve to it. The back part that is spared is actually supplied by 2 different arteries, a right and a left posterior spinal artery. And these arteries all have some anastomoses, so the exact location of the injury is going to be variable, but the concept will be the same. And finally, although it is not actually a spinal cord injury, I would like to talk about cauda equina syndrome. Cauda equina syndrome is not a spinal cord injury. You will recall that the cauda equina is made up of all those dorsal and ventral roots that are coming down from the lower segments of the spinal cord after it has ended in order to get to the vertebral levels they need to exit the vertebral column. It is, however, a spinal region injury because all of these dorsal and ventral roots are housed within the spinal canal. It is involving lumbar and or sacral nerve roots. Different roots will be affected depending on what is creating the cauda equina syndrome. Frequently, it is due to a problem with a disc or spinal stenosis. Cauda equina syndrome is an example of a polyradiculopathy. A radiculopathy is a lesion of a nerve root, and poly indicating there are many, and often it's going to be asymmetrical. Signs and symptoms of cauda equina syndrome include pain, sensory changes in a radicular pattern, which means an asymmetrical multidermatomal pattern. Whichever dorsal roots are getting impinged in this particular patient will demonstrate some sensory impairments. An asymmetric lower motor neuron presentation in the lower extremities with flaccid paresis or paralysis. Depending on the extent of compression on the ventral roots, it could be just a mild weakness or it could be much more extensive, such as a foot drop. If there is severe enough compression that it reaches the sacral root levels, which are positioned the most medially in the cauda equina, this person will experience dysfunction of the anal and bladder sphincters. If your patient comes in and describes symptoms that make you suspect cauda equina syndrome, or they're given a diagnosis and come to you with the diagnosis of cauda equina syndrome, and they report to you a sudden onset of difficulty with bowel and bladder control, this is a red flag. This means that there is such significant compression. They are likely to end up with permanent damage if more medical intervention is not performed. So this would be something that would make you want to talk to the physician and let them know that the patient is now reporting this sudden onset of sphincter dysfunction. The physician may need to do additional medical workup. Now I'd like you to brainstorm with your peers why you would see the signs and symptoms I indicated above and why you would not see upper extremity signs and symptoms, but only lower extremity.